Tokyo Live
Endoscopy
Endoscopy 1.
Dear colleagues, now we'd like to start a virtual live demonstration session, ESD for esophageal neoplasia. I'm Kashida from Kinda University, Osaka, Japan. It's my great honor to moderate the session. First of all, I'd like to introduce the demonstrator. Dr. Hiroyuki Ono is Chief of Endoscopy Division and Medical Deputy Director of Shizuoka Cancer Center Hospital, Japan. He is a world-famous endoscopist and a real pioneer of ESD procedures. Without him, ESD technique might not have been developed. It is also my great pleasure to have Professor Haruhiro Inoue, the course director and the president of Japan Gastroenterological Endoscopy Society, as a commentator. Professor Inoue, thank you for inviting me as a moderator, and thank you for joining us for this session.
Kashida-sensei, thank you so much for your introduction to me.
Thank you. Now let us start the demonstration. As far as I understand, we have a very tough case today. Dr. Ono, would you start the presentation now?
Okay. So thank you very much for kind introduction, Professor Kashida, and thank you very much, Professor Inoue, for inviting me such very excellent and great live demonstration. It's my great honor to be here. So and I start my presentation. Okay. Hello everyone. I'm Hiroyuki Ono, Shizuoka Cancer Center. Today's case is esophageal superficial cancer. Patient is a 79 years old male, and he underwent esophageal ESD 2005. However, cancer invaded submucosal layer, so he also underwent chemoradiotherapy, about 45 gray radiation. After that, he underwent ESD 4 lesions in 2012, 2016, 2018. And now he has had, had esophageal ESD 5 times and chemoradiotherapy. And present illness, a new superficial esophageal cancer was detected by surveillance endoscopy. So now you can see endoscopic picture, and you can see the ESD scar, many ESD scars. And cancer is here. So cancer is about 8 millimeter in size and very tiny lesion. So usually, such lesion is very easy to do ESD. However, he has many ESD scars, so maybe there is a severe or moderate fibrosis. So let's start ESD, and I use IT knife nano and Bio3 for generator, and for injection sodium alginate solution. So you can see the ulcer scar with ESD scar here, and lesion is here. So of course he has many unstained area by using dye. However, this lesion shows the pink color sign after iodide spray.
So
yes.
What kind of knife are you using for marking? Is it IT nano?
This is a needle type.
Needle knife, of course.
I use a spray coagulation mode, like APC. So proximal area maybe the fibrosis existed. So you can see the little bit pink color sign here.
Yes. Yes.
And I inject the sodium alginate solutions. This is a 3 times speed video, and that this video edited minimum, so you can see the almost of all procedure of this ESD. This area little bit difficult to inject. Maybe injection solution injection into the subepithelial up to subepithelial area, not submucosal area.
Where did you start the resection? Incision, mucosal incision. Where do you start?
Distal end, distal side.
This.
Yes. This is a routine procedure because ITNF is a device which is from distal side to proximal side.
And away from the scar?
Away from scar. Okay. Here is distal area is also has no scar.
Okay.
Yes,
So
it is well liquid.
First, I start to incise from distal side to proximal side.
What mode did you use for this incision? What kind of mode?
End-cut mode.
End-cut.
And you can see some bleeding. So in such cases, I use IT knife as cut submucosal layer and also stop the bleeding.
So at the same time, you mean?
Yes, yes.
Okay.
So as I continue incision, so maybe IT knife has a good good device to stop bleeding.
And were you using coagulation mode?
This is a cutting mode, swift coagulation.
Swift coagulation.
Swift coagulation.
Okay.
So cutting is and coagulation. Swift mode can cut and coagulate.
Ono sensei, in the esophageal ESD, you recommend the IT nano than so IT original.
Yeah. So I recommend IT knife nano because the electrode of the bottom of insulation tip is smaller than original IT knife 2.
IT knife compared to IT knife 2.
Yes, compared to IT knife 2. So sometimes IT knife 2 is IT knife 2 has a good cutting ability, so sometimes dangerous for esophagus because esophageal wall is thinner than gastric wall. So I strongly recommend to use IT knife nano for esophagus.
Okay. How about for colon?
Yeah, of course, we use IT knife nano.
Okay.
So this area is maybe has a fibrosis. So I cut the end of circumferential cutting.
So you cut all the circumference first? All the circumference?
All circumference first. It is not necessary to remain the mucosa, I think. So you can see this part, whitish, whitish. So I inject the solution containing indiocarmine, but this is not stained blue.
Because of the fibrosis.
Yes.
You can't see the blue color.
Yes, yes. I mean so. So now you can understand this area is has a fibrotic change. However, this area you can see the blue layer, stained blue. You can see submucosal layer stained blue, proximal side.
But center is not lifted.
Yeah. Here you can see blue layer, blue submucosal layer. So this area is not so difficult to dissect.
Yes.
So the oral side looks more difficult.
Yes. Maybe the
Or,
most difficult side is oral. This part. Maybe it's difficult to dissect. So first I dissect the distal side. So I insert IT knife. No. Now. The IT knife nano has a insulation tip. So insulation tip avoid that electric current go deeper. So we can cut such procedure.
So this is a so-called deeper cut in the
Yes.
submucosal layer.
Yes. Yes. So I attach the initiation tip to the submucosal layer, and then I move to lateral. I move that laterally.
Both lateral side.
Yes, both lateral side. Distal side to lateral side. So maybe the needle type knife is difficult to such cutting procedure because needle type knife has no insulation tip.
So with needle type, we should look at the submucosal layer directly. So it takes more time to dissect.
So I think the IT knife ESD is faster and safer technique. Maybe safer. So after circumferential dissection, I start to dissect this proximal area.
I think I can see the muscle layer now.
Yeah. Yes. Because I cannot see the submucosal layer in proximal part. So maybe this area adhesion the submucosal layer and muscle layer. So I have to cut. Maybe I cut deeper.
Yeah.
Maybe
It looks like a perforation.
muscularis mucosa. Yes, muscularis mucosa.
Not the proper muscle there.
Yeah, because longitudinal.
But I cannot see here. I cannot see here, so I cut another area.
Yeah.
I'm afraid that there was something like a hole.
I'm afraid. So I have to cut another area. Not to see there. But anyway, after that, I have to see here. Oh, maybe at all.
Yeah.
So that was a proper muscle layer, no? Was
Proper muscle layer. Lesion with severe fibrosis. I have to dissect more carefully.
In spite of the perforation, you continue with the dissection procedure. So some people might think that you had better put some clicks for the perforation, but you do not do now.
When I suture by clip first, those clips sometimes disturb the procedure to continue ESD. So I first I want to remove first the lesions, and after that I want to suture.
Yeah, of course I understand that, but you must be very quick for the procedure. Maybe more air will leak after a long procedure.
Yeah. So fast ESD is necessary, I think, for such cases. And of course, I check the patient status, saturation of oxygen and blood pressure, and so on.
May I ask Ono Sensei?
Yes.
So in the IT9 procedure, traction device doesn't work.
Yeah, traction method is work very good. Work very well. So maybe in this situation, my mental is not so calm. So I continued without clipping, without traction method. But after that, I find to use traction technique. So I have, of course, I have made many perforations at ESD, but on that time, my mental is usually not calm.
So, may I ask again? So, this patient receives general anesthesia or sedation?
Sedation.
Sedation.
Only sedation. I use petidine, chloride, and midazolam.
Thank you.
And sometimes and dexmedetomidine I use.
No. And
so in such situation, so dissection is a little bit difficult. So I think I should use traction procedure.
So you don't use traction method from the beginning, but only in difficult case?
No, I usually use initially to use a traction method. But this lesion has a severe fibrosis, so first maybe the traction method is not so useful initially.
At the beginning.
At the beginning. So I decided to use.
So now I can see the clip and the thread.
Yes.
Did you use dental floss?
Yes, I use dental floss. Dental floss is very easy to attach the clips. Right. So I think the traction method changes the esophageal ESD. How about the Professor Inoue?
I totally agree with Ono Sensei's comment. So traction, it works very well.
So I can see the cutting area easily after using traction method like this. And I move IT knife just on the muscle layer like this.
Yeah, I can see inner muscle layer, maybe.
Yeah.
The circular muscle layer now.
Yeah. Inner muscle.
Right.
So I check the patient status, and the patient status is stable. So I can continue to do the ESD procedure.
Patient was stable, but you may not have been very stable mentally. Oh, maybe you were approaching to the last cut.
Last part. Last part. So traction method makes the procedure faster.
Yes, definitely.
So anyway, so ESD completed.
Yes.
So completed. So
And what will you do with the perforation?
so ESD is okay, but I have to do treat this perforation. So I use clips.
Suture the perforation.
Suture the perforation.
And did you use ordinary clips or special clips?
Ordinary clip, easy clip.
Just easy clip.
Just easy clip. Now we have many clips and OTSC, but OTSC is difficult to such narrow situation. Narrow lumen. First, I failed like this.
One side clipping.
Yes, one side clip. So I have to be cool, be calm.
So
then
disposable one-way clip is like this, so it's sometimes difficult. We cannot repeat the procedure one way.
I think.
So
I think so. I agree.
Yes, like this, open and close clip.
Yeah.
It's also one way. But Ono Sensei's technique, so good.
So yeah, it succeed. I succeed. I suture both sides. And another side, another distal area.
And did you try to suture only the perforated site or hold the wound? All over the wound or only the perforated site?
Yeah, only the perforated site because whole wound is very wide, so it is difficult to suture for me. Maybe I'm not sure, but if we suture the whole one, stenosis occur.
Yeah.
How about Professor Inoue?
Yeah, so if we close this together with mucosa, it may cause stenosis in this area.
So maybe it's better to suture only perforation hole. So 3 of 4 clips is effective. Maybe okay, but I try to distal side for more one clip here. There's more one clip here.
Yeah, at the center maybe.
Yes, at the center. So it should be pinched, not stabbed, because if we stab the clips, sometimes the muscle layer is very rough, so sometimes difficult to suture. So it should be pinched.
So you should not push the clips strongly against the bone, do you mean?
Yes. I mean so.
And in such a case, do you give antibiotics after the procedure?
Yeah, I use antibiotics maybe the 2 days. And I check the hole. There are any remaining hole, but okay. So I think another clip is necessary or not. Maybe this area not hole, not perforation, but this is little bit the proper muscle layer is rough, so I decide to suture.
Yeah, there's some gap between the fibers. Yes.
Yeah. So the Professor Kashida translate very well for me. Thank you very much.
No. Yeah, I'm trying to understand myself.
So after clipping here, and the suction in the air is important point, I think, to clip. So anyway, so it is easy to see the lesions. But so I think it's finished completely. And this lesion is esophageal cancer. Cancer invade up to LPM, T1A LPM 8 millimeter. And this is a perforation hole, and the right side is after suturing, and 1 month later, completely covered by. So maybe,
great.
Yeah, very quick. So little bit surprised. Only 1 month later, only 1 month the lesion healed, I think. So I want to say take home message. So do not overdo and operate carefully and get a skill for perforation. So thank you very much for your kind perforation, kind attention. And so thank you very much, Professor Kashida and Professor Inoue, for help for me.
Thank you very much for exciting presentation. So you should operate carefully, but quickly too, maybe.
Yeah.
Especially after the perforation.
Yeah.
So, Professor Inoue,
yes.
Can we have some comments for this case?
So maybe I think thank you very much, Ono Sensei. It's a very exciting procedure. So, for example, in this particular case, so how many days you keep the patient fasting?
Usually, I kept about 2 days. 2 days.
2 days fasting.
2 days fasting.
Then start the water.
Then start water.
Yeah, water.
And the next day, on next day, the patient can have food.
So you mean the day four patients start the liquid meal?
Yes, for perforation case.
Wow. So the reason why. So do you do the second look by endoscopy before starting meal?
Yes, one day before starting food, I do endoscopy, second look endoscopy.
Thank you so much. Kashida-sensei, may I ask him one more?
Yes, of course. Go ahead.
Yes. One more question is that this patient receives radiation as well, 45 gray radiation. Yeah. So is there any difference without radiation case and like this case, a radiated case? Any difference in when you approach to a deeper layer?
Yeah. So this patient received only 45 grays. So if he has no ESD scar, maybe it is not difficult to do ESD. That shows severe fibrosis. And if he received 60 gray full dose radiation, maybe fibrosis changes occur. So sometimes difficult to dissect the submucosal layer. However, I think ESD fibrosis after ESD is most severe. So severe fibrosis usually see after ESD, not radiation. I think.
So this patient is a particularly proximal part. It's difficult to separate the mucosa from muscle layer. This patient. So. Yes. The major reason is not radiation, so it's mostly previous ESD. Sorry.
I think so. So major reason is for ESD scar.
Thank you so much.
So the time is limited. The case was a very difficult case, and it was perfectly done because of Dr. Ono, because it was Dr. Ono who performed the procedure. So my take-home message is for the beginners, do not challenge such a case by yourself. So only experts can do that. Yeah, now I'd like to close this session. Thank you again, Dr. Ono, for exciting presentation, and thank you, Professor Inoue, for your nice comments. Thank you very much for your cooperation.
Thank you very much.
Thank you so much, Ono-sensei, Kashida-sensei.
Thank you very much.
Thank you.
Thank you.